Well, good morning or good afternoon, everyone. Thank you for joining us today. Let's go ahead and get started. My name is Kimberly Mueller. I'm with Health Insight, and today we're going to be talking about brief interventions to mitigate suicide risk, focusing on caring contacts, patient education, and other patient engagement strategies. Can I have the next slide, please? As a reminder, we are recording all of these sessions, so if you do object, please disconnect now. But this is the fourth and final event in our four-part series on suicide prevention and primary care. All events have been recorded and are archived on our Health Insight YouTube channel, and I'll be putting those links in chat here just shortly. Next slide, please. Just a few remarks to give you a bit of an orientation to our Zoom platform. I want to draw your attention to the icon on the lower far left. That's where you can mute. Ensure that your line is muted when you're not speaking, please. If you're calling in by phone, you can press *6 to mute and to unmute. Later in the presentation, we'll have a time for question and answers, and you're certainly welcome to unmute yourself and pose your question verbally at that point if you'd like to. And if not, then you can see the icon that's on the lower right side of the screen that says chat. We invite you to enter any comments or questions that you might have for our presenters today during the course of the presentation. And again, we'll get to those at the end of the presentation. Next slide, please. So here are the objectives for us today. We're going to be talking about some strategies for managing suicide risk during care transition and some brief interventions, including patient education and caring contacts that can be used in primary care. Next slide, please. So while you're listening to the presentation today, I want to just ask you to be thinking about the brief interventions that you're currently using in your practice to reduce suicide risk for your patients, and what elements of continuous quality improvement or the zero suicide framework can you use to improve the suicide care for patients in your practice. Next slide, please. We've got some great speakers for you today, really excited. So their full bios are located in the slide deck that will be distributed after the webinar. But briefly, Andrea Hood is the Suicide Prevention Program Coordinator for the Zero Suicide Project with the Utah Department of Human Services, Utah Division of Substance Abuse and Mental Health. And we also have David Eldridge, a licensed clinical social worker here with the University of Utah Community Clinic's Behavioral Health Integration Team. So Andrea and David, I'll hand it over to you now.
Great, thank you. We very much appreciate the opportunity that we have to visit with you today regarding suicide prevention through safe care transitions in particular. Just want to mention, as working within the Behavioral Health Integration Program, I've had an opportunity to work more closely with our primary care providers in our outpatient clinics. And I just want to indicate my level of respect continues to increase. Y'all work incredibly hard, and just the caring and concern for the patients that you have and for our community at large is readily apparent. I think it's also fair to acknowledge how behavioral health issues have increasingly hit primary care for a myriad of reasons. As we start off today, one of the things that I'd like for you to keep within your framework as we discuss this is really as we think about crisis and how that relates to suicide prevention, and really thinking about crisis as this definition. It's really a time-limited perception of an event as intolerable and or beyond one's coping and or resources. So the key elements there: time-limited perception, that it's viewed as intolerable or beyond coping and or resources. And so the elements that we'll talk about today really do address how to ameliorate crisis as well. So with that, I will turn over to Andrea.
All right, thank you. So I wanted to share with you, and kind of through that framework of crisis and what a crisis is, that most people, since they're feeling beyond their ability to cope within themselves, most people who do die by suicide actually seek medical attention in the weeks preceding their death. And most of those are not accessing behavioral health services. In fact, about half of them visit a primary care physician within the month before their death. So really, you are ideally placed to help identify these patients and get them the appropriate treatment and help that they need. And part of that will involve referrals and transitions in care. So I wanted to share some information with you about care transitions and why they're such a high-risk time for our patients at risk of suicide. And first of all, we'll talk about discharge from inpatient care. So after discharge from inpatient care, We may falsely assume the person would be doing better. We may hope that they may be doing better, but suicide risk is actually really high, even after they've been receiving intensive inpatient care. It's up to 100 times higher than the general population, and it peaks in the first week after discharge from inpatient care, but remains high for several months after. And it's easy for these individuals to fall through the cracks in our current system because there are some cases where no provider feels responsible for them. I've discharged on to the next provider. It's now their duty to follow up. So sometimes no provider is really checking in on them during that care transition. And for this and many other reasons, most suicide attempt survivors who are treated in a hospital for their suicide attempt never attend outpatient appointment or engage in outpatient treatment. So there's a lot of reasons for this, lack of engagement in mental health care and then lack of follow-up to referrals and appointments that were made. And some of these reasons can be financial, logistical barriers, of course, but there's also a lot of barriers that relate to the individual's beliefs about treatment. And that could be due to past negative experiences or stigmas about mental health care. And we're going to be addressing that today in our section on engaging the patient in treatment and how we can use certain strategies to promote their engagement in treatment. So fortunately now we have several evidence-based strategies to help the patient stay safe and help them to stay connected during transitions in care. And whether that transition is from inpatient to outpatient care or from your primary care setting, being referred to an outpatient mental health provider, I think these strategies will be really helpful. So these are the 3 sets of strategies that we're going to be discussing to improve patients' engagement in care and their safety during care transitions. So first off, we're going to talk about caring contacts. So what is a caring contact? Really, it's just a brief communication from a care provider that's just expressing your concern for them, your care for them, reminding them of resources. This could be done over phone, email, text, postcard. All of those have evidence of being effective. And so really what we're going to be saying in those contexts is something like this. Hey, it's been a few weeks since your last visit, and we're just thinking about you, and we hope that you're doing well. And if you should need support in the future, we're here for you. Here's a phone number you can call. Here's the Suicide Prevention Lifeline. So it's very, very simple, very brief. So why does this work? The theory is that it increases feelings of connectedness, especially for very socially isolated patients. That could be very important. And it reminds patients of resources and increases the likelihood, potentially, of that patient engaging in treatment as they develop more positive feelings to treatment because of these caring contacts. So generally, caring contacts follow a preset schedule, and they have ranged in studies from anywhere from 1 caring contact after an appointment or a crisis encounter with a patient to up to 24 caring contacts over a series of up to 2 years. So you could mail out just 1 or 2, or you could schedule and do 1 every month for an extended period of time. It's kind of up to what you think would be feasible in your setting. So I'll share with you a couple of the research articles that have been published around caring contacts. So there was one published in 2001 where they sent 12 signed letters over a 2-year period to persons who are discharged from inpatient care. And these were individuals who had declined further treatment. And so they were randomized to either receive this intervention or to receive no follow-up. And they found that there were more than twice as many suicides in the no follow-up group compared to the follow-up group for the first 2 years. So a very significant reduction in suicide death for those who receive these caring contacts. And there's also been published in 2013 a review of the evidence by Luxton and colleagues that showed multiple randomized clinical trials that demonstrated that providing these follow-up calls and or letters significantly reduce both suicide attempts and deaths. And it is really rare in suicide prevention research because suicide prevention is so complex, right? That such a simple and inexpensive intervention could reduce suicide deaths is pretty remarkable. And so the question is now not, will this improve my patient outcomes? I think that that's been, pretty clearly stated in the research, but now the question is, how can I actually implement this in my setting? And that's a little bit more of a challenge. And so I hope that you'll be thinking about how your office already does things that are similar to this, like emails, automated text messages, appointment reminders, and how you can use your staff and your technology that you already have in place to do caring contacts in your setting. So here's an example of a caring contact. And we'll send out, you'll have access to these slides, and we'll also send out some other examples in the follow-up email after this webinar so that you can feel free to use these, copy and paste them, use them however you see fit in your setting. And here's an additional example of a caring contact. This one is more tailored to when a patient at risk of suicide no-shows for an appointment. And so the gold standard, if a person at risk of suicide does no-show for a scheduled appointment, would be to call them, try to check on them, because it could indicate that the situation has gotten worse and the crisis has escalated. And then call their emergency contact if possible. And if you can't get a hold of either of those through phone calls, then you can send a caring contact like this to try to help re-engage them in care. So the last thing on the subject of caring contacts that I wanted to share is this kind of more advanced version, and it's called structured follow-up and monitoring. So rather than just a text or a card in the mail, this is using a phone call to call a patient either during a care transition or between appointments and just ask how they're doing, ask how they're using the safety plan and edit it with them on the phone, ask how they've addressed their access to lethal means. Hopefully you already addressed that initially in the office with them, but this is a great opportunity to check on it and make sure that that home environment was made safer. And then encourage them to attend their next appointment and kind of problem solve any barriers that come up. So this is a great tool for, especially for high-risk individuals. And I encourage you to think about how your medical assistants, nurses, front desk staff, or even collaborative community partners could help to provide this type of monitoring between appointments or during a care transition. Okay, so that was the caring contact section. And this leads us over to our next section on care transitions and some strategies that you could use during a care transition. And so really there are a myriad of strategies that we actually describe in our toolkit. I'm gonna go back to that slide in just a moment. So in this year, the office that I work for, the Utah Division of Substance Abuse and Mental Health, created a toolkit for safe care transitions for suicide prevention. And it has a whole menu of strategies, ones that we discussed today and others, and it goes into much more detail. And it also introduces you to a sample office protocol. So what could this look like in my setting? How would we write it out in a protocol format so we know exactly who is supposed to do what and when? And then it also gives you some resources and examples, including templates for things like caring contacts or a phone script if you want to do follow-up phone calls. So that toolkit covers many of these topics and addresses things like rapid appointment scheduling. So does the person at risk of suicide, if you're referring them, say, to an outpatient mental health provider, do they walk out of your office that day with the appointment already made? And when is that appointment scheduled for? Ideally, it would be scheduled within 48 to 72 hours of them seeing you. And I know that that's challenging in the real world, right? So sometimes creating relationships with mental health providers can help to make that rapid appointment scheduling more possible, but you're really doing the best that you can to make that a reality. And then also things like provider communication. So once that individual's appointment has been set with an outpatient mental health provider, then are we contacting that provider and sending them any relevant information that they need, a documentation before that appointment takes place? And do we call them to check that they got that information and also discuss the patient with them if necessary before that appointment? And then also engaging their social support network or care navigators, case managers, or peer specialist supports, so that when that individual at high risk is in a care transition, they'll have these kind of extra supports around them to motivate them to engage in their follow-up appointment and follow the treatment plan. And if that patient that you're working with doesn't have access to a lot of social support or doesn't have a case manager, a good resource to try, especially if they're lower socioeconomic status, they may qualify for these resources through the local mental health authority in your area, who offers a lot of great resources of case management and peer support. Okay, I'm going to turn it back over to Dave.
So the third area that we want to talk about is patient engagement and brief interventions. And that includes warm handoffs, motivational interviewing, and psychoeducation. And so when we talk about warm handoffs, there's a few elements that are really important to be cognizant of in this area. One of the things is, in the areas that you work, being aware of thinking about your area as a system of care that has a seamless, that it's a seamless system of care. And so ultimately, when we think about patients and when we hear of behavioral health issues, there's really two elements that are critical, is access. And then also with access, there's so much stigma attached that when there is that readily available time that a person needs, wants, and deserves services, we want to catch them quickly with access. So we really want to be able to provide the right care at the right time in the right setting. And so those are really vital elements. In terms of with warm handoff, we really also look at the rapport and the enhanced patient engagement that occurs before the transition of care. So it really is looking at introducing the individual to the next service provider. And with that, it's also important that our documentation is done in a timely manner as well, so that the person that is going to be receiving the warm handoff has the clinical information about the patient. We want to be able to be available to primary care providers for curbside consultation. So this element is really addressing our behavioral health integration program, and I know other organizations as well have behavioral health embedded in various settings. And one of the things that social workers and other behavioral health providers can do is provide and extend that consultation to our physicians and APCs. And then that also, I know the model that we're operating under is a warm handoff model, where we are actually, as social workers, readily available within the clinics in real time to respond to patients that are in crisis or have even non-emergent behavioral health needs. And then that leads also to scheduled appointments. So it's really an integrated model rather than just a co-located model of care. Also, when we look at the warm handoff model, it does increase engagement, so it decreases no-shows. Moving on to motivational interviewing, I would imagine most of you are familiar with this, and I just want to touch on this in terms of engagement. It's really an evidence-based, patient-centered method in which we address the common problem of ambivalence that people have about change, and really do that through paying particular attention to the language of change and the language that we use. An element in this as well is when we think of safety planning with the patients. Safety planning really is a dynamic and ongoing process, and it's really looking at seeking solutions and preventing risk. And so part of the motivational interviewing process is continuing to engage also in that safety planning, so that that's an ongoing process as things are changing in the patient's life. In terms of motivational interviewing, traditional model of service provision has had a tendency to be more authoritarian, more confrontational, educational, and more directing. And the engagement level typically has been less than ideal with patients. And so motivational interviewing really operates under the premise of partnership, acceptance, compassion, and evocation. And, just to give you a couple of examples of what that might look like, it would be something maybe along the lines of this as you're talking with a patient. So you indicate you're feeling a significant sense of despair now that you're living with diabetes and you want to give up. You've also indicated you're interested in learning more about carb counting. So you would pose the question, how do you make sense out of these two different views to the patient? So it's helping them in an engaging, compassionate way, helping them explore the ambivalence that they may have like to just give an additional example on that too. So let's say you have a patient that comes in that's really struggling just with depression and hopelessness and suicidality. You may say something like this. So you've indicated that life feels hopeless, and at the same time, you also indicate you feel a need to be a part of your granddaughter's life. Help me better understand how you manage both of these in your life. And so you're just really helping them think about the ambivalence that they have in their life. And motivational interviewing, when it's presented in that way, it's non-judgmental and it's engaging, and you will gain a lot of information about the person, which can then move to planning. In terms of brief patient education, I think the key elements on this are really that we want to help them understand the nature of the condition, whether it's a behavioral health condition or a medical condition. On chronic medical conditions in particular, it's important to really be aware of the impact that learning that you now have a chronic health condition, the impact that that has on the person. If you think of it this way, when you go in and if you have a cold, you know that the symptoms are miserable, and but ultimately that it's going to run its course and you're going to feel better. But with a chronic health condition, it's unknown. And chronic, by definition, is indicating that it's chronic. And so there's a real need to educate individuals on the nature of their conditions and what they can expect. And then also in terms of the patient educational component, really looking at both risk and protective factors, and how can we augment our service provision with professionals, with community resources and natural support systems as well. But also looking for those people in their lives that keep them socially connected, because we know that's a key element in preventing suicide. Educating them about the type of treatment and treatment options. And again, this is, for both medical and behavioral health illnesses. Talking about medication instructions so they're clear on how they can be utilized, and then having that collaborative patient-centered dialogue with them so that they will be engaged in decision-making with you. And a really highly key element is lethal means restriction. Really talking to them about within their natural environment, how can we reduce lethal means? And I know when we think, especially with firearms, we want to, because that's such a lethal means, really looking at responsible firearms ownership. That language tends to resonate with all parties. Then we want to make follow-up recommendations, help them become aware of the signs of a worsening condition and how to respond. Provide them, because of the state, if they are in a crisis at the moment, their ability to hear a lot of what you have to say is going to be reduced. And so we want to make sure we also provide things in a written format for them, and especially the National Suicide Prevention Lifeline and the Safe Utah app, and make sure that they're set up with that and they know how to utilize it. Furthering the brief patient education piece is just helping them move to being able to view of what recovery might look like for them. And then actually moving to goals and what the goals might look like for the various treatment strategies. And then the key I've found over the years, and I've heard this from so many patients, is the confidence that we instill that treatments are effective, and we're instilling hope. That is, I can't underscore that enough. How using multiple treatments can be beneficial, and then supports and self-help available in addition to the treatment, and also the free patient education materials that are available through our National Alliance of Mental Illness, NAMI, Division of Substance Abuse and Mental Health, and then also SAMHSA. And so with that, I'll turn it back to Andrea.
All right, thank you. So we hope that as you've kind of heard some of these strategies, that you'll consider how you can incorporate them into an office protocol of, so you'll have a structured way to respond to a suicide crisis and to manage care transitions, and then be able to track that in your EHR and see how you're applying that office protocol, and look for opportunities to do quality improvement and make sure that that these interventions are being applied both with consistency and with a high level of quality. And that's really what the Zero Suicide Quality Improvement Framework envisions for these types of suicide prevention interventions. So we are grateful for your time here today. If you want to learn more about zero suicide or about care transitions, you're welcome to email Dave or myself, and we'll open it up now for questions, either through the chat box or you can unmute yourself. So what questions do you have?
Great, thank you, Andrea and Dave. So yes, folks, please feel free to use the chat box to enter any questions or comments that you have for Andrea and Dave. I've also been putting in links to many of the resources that they have identified on the slides into the chat box as well. So there's a wealth of information that's included in there. First question we have is that for those that don't live in Utah, can you share resources that exist in your state? And I guess maybe Andrea, you can kind of comment on the fact that Zero Suicide is a national campaign, and so maybe you can kind of help direct folks as to where they would be able to find sort of their way to local resources.
Sure, yeah, so you can visit zerosuicide.sprc.org, and that will give you resources that apply nationally. And as far as, and that's for, you know, your clinical quality improvement and for looking for tools and strategies that you can implement clinically. But if you're looking for like patient supports that apply to your state where you can refer patients to, then the National Suicide Prevention Lifeline is a great place to start. You can even call them as a provider and get some information on what a patient can expect if they call the Lifeline. And they're always available to provide technical assistance and to provide consultation, even to providers and to family members who are trying to help a loved one in need. And also every state has their, you know, their state-based mental health system. So we can, I think in one of the previous follow-up emails, we sent out information for each of the state suicide prevention coordinators, and we could send that again this time.
Sure, and I guess too, Andrea, is that, like, for example, the toolkit that you were talking about, that's something that, while it may have been developed in Utah, probably contains information that would be useful to somebody in any state. It's probably not specific to. So would you like to maybe just take a couple minutes to kind of go through that toolkit and show some of the information in there that anybody in any state could benefit from?
Yeah, most of that is not specific to Utah. You were right about that. It's resources and based off of national research. So, well, that's not it.
Here's bottom left.
Oh, yeah. Okay, here we go. Okay, so this is the front page of the toolkit, but I just wanted to share with you so as you scroll down, it goes through a menu of different options and strategies that can help during care transitions. And so we structured it in a format of good, better, and best, just based on the resources that were needed to implement the strategies. At like lower level of resources were needed to implement the good strategies, and a higher level of resources were needed to implement the best strategies, and often the best level strategies have better outcomes as well. And then you can see that we kind of developed a guide for office protocol as well. So you can take some of these menu of options and actually put them into like a practical protocol of what does this look like in our workflow, in our setting. And so this is just an example. You can edit it, tailor it as you need to for your office. And then there's some additional resources about patient education, some examples of how to have this conversation with a patient, and then some examples of caring contacts in here. And so these, you're welcome to use them and apply any of these resources regardless of the state that you're in.
So Andrea, I think there were some additional questions that came in that were sort of asking about the level of staff expertise in order to implement some of these. And I would imagine something like motivational interviewing is probably best done if you've had some training in motivational interviewing. But as far as like the caring contacts, for example, that you have on the screen, would you say that this is something that a medical assistant could do, working under protocols that are probably available in this toolkit, just so that would be a place where folks could get started even if they don't have specialized behavioral health staffing in their practice?
Absolutely. So what you could do is have these caring contacts sent out through text or through a letter or postcard or something like that, as long as it was, private and confidential for HIPAA reasons. And then that text and postcard, if it was a text, you wouldn't want the patient to be able to respond and engage in a dialogue with staff about their risk unless those staff were trained in suicide prevention. And again, if you want your staff trained in suicide prevention, I do encourage that. You can seek that out through your state suicide prevention coordinator by emailing them. But if your staff are not trained, then this kind of caring contact really can refer patients to call the suicide prevention lifeline if they have a crisis, rather than calling your staff or your office team.
Great. And just one last question, because I know we're sort of at the top of the hour, and we did have a webinar that was speaking about screening, and maybe we can go back and look at that. But a question came about, for individuals who present to EDs with suicide attempts or ideation, is there value in doing a suicide screening questionnaire, or is it superfluous at that time? And if there is value in doing such a screen, what do you recommend? The recommendations might come more from reviewing that recording, but just in the simple question of doing a suicide screening questionnaire, is it superfluous or not? What would you advise?
Depends which suicide screening tool you're using. It could still give you great information about the nature, intensity, duration of those suicidal thoughts if you're using the Columbia. But hopefully, you could go straight into the full risk assessment.
Yeah, there's the lifetime version of the Columbia as well that really does provide a lot of information. So it does also, it stratifies risk for one thing, but I think even in that setting, that could be a very appropriate use of the lifetime version of the Columbia.
Great. Well, thank you. And I appreciate that we're over time. So thank you for taking a few extra minutes with us. And I guess I would just reiterate, Andrea, if someone wanted to have an additional conversation with you, they could reach out to you through your email, and you could kind of talk them through some of the pros and cons of the different screening tools. And again, the webinar that we did on screening a few weeks ago, that link is available. So that would certainly be a resource that you could access as well. But to wrap up, thank you so much, Andrea and Dave, for your presentation today. And thank you to everyone who participated and posed such interesting questions. Appreciate your time and enjoy the rest of your day.
Thank you.
Thank you.